Hello everyone, welcome everyone. My name is Angeline True. I'm here from Prestantia Health. Online I've got my colleague Tamika Nugent, who's there somewhere, I can see, and Dr. Paresh Dauda will be joining us as soon as he can.
I'm here.
Oh, hi Paresh, sorry I didn't see you join in there. So yes. So welcome everyone to this program. So it's our diabetes program 2024, and this is our online series recognizing the fact that we actually led a similar program last year, which was predominantly face-to-face. So today's workshop that kicks off this program is around what matters in diabetes care. So I'm really pleased to see so many of you join this session. So before we start, I'd like to acknowledge traditional custodians of the land on which we meet and of the many different nations across the regions. We pay our respects to the elders past, present and emerging as the holders of the memories, traditions, the culture, the spiritual well-being of First Nations people. We recognise their continuing connection to land, water, culture and community. We acknowledge any sorry business that may be affecting the communities as a whole, and in the spirit of reconciliation, partnership and mutual respect, we will continue to work together with Aboriginal and Torres Strait Islander peoples to shape a health system which better responds to the needs and aspirations of the community. And that's what we're here today to do, to think about what matters to people, families and communities. What matters to the people who deliver those services, how we measure what matters to those people, and then in the next session think about how we shape our services to better address those needs, those aspirations, those preferences and their views. So online we've got Paresh. Paresh, do you want to do a quick introduction?
Yep, great, thanks Ange. Hi everyone. So as Ange says, I'm Paresh. I'm a GP based in Canberra. Spend about half my working week doing clinical work, and that clinical work's really focused on people with complex and chronic care needs. So I do a lot of sort of elderly care, aged care, disability care, palliative care. The rest of my working week is taken up by a whole bunch of different roles and functions. Some academic affiliations with the business school at UNSW and the Faculty of Health at University of Canberra. Also do some advisory work with the New South Wales Agency for Clinical Innovation, and I used to with New South Wales eHealth, although I've just joined a task force this morning about AI in healthcare across New South Wales, and a framework for that, and then various other things around advisory work, both at Commonwealth, state and territories, and also professional bodies like the College of GPs. So thank you, delighted to be here. Diabetes is one of the areas that really interests me. It's also an area where our practice is doing some quality improvement work as well. So really looking forward to being with you as a facilitator, but also learning from you as well. So thank you.
So thanks, Paresh. Now you're probably sitting wondering, how does he do all of that? Does that man ever sleep? The answers are, we don't know. We've worked with Paresh for 13 years and we suspect he doesn't sleep. So yes, so I'm Angeline. I'm the principal consultant at Prestantia Health, got a background in health, social care, higher education. My passion is primary healthcare and the equity agenda, and thinking through how we can develop services and systems to better address consumer needs. So thanks everyone. So I'm going to give a quick introduction to the programme, and then I'm going to invite you to give some feedback. So we will be using polls and we will be using breakout rooms and whiteboarding sessions throughout this workshop. So a quick overview of the programme. So here we are today. We're considering what matters in diabetes care. Our next workshop, 20th of March, is around delivering care that matters. So thinking about how we develop team-based models of care and how we leverage chronic disease management arrangements, best use of MBS, best use of other source incomes to actually drive the development and delivery and the improvement of the services we offer. And then our final workshop on the 8th of May is about embracing the future of primary health care, considering opportunities in strengthening Medicare. So thinking about the changes to the chronic disease item numbers, and that's on the horizon. So how do you leverage those? How do you set yourself up for success in relation to those? And how do you sustain that quality improvement approach? So what you'll see is interspersed between those workshops, those stars that indicate the coaching sessions. So in terms of the marketing material that was provided, what we actually explained is that this is a program, and actually it's an improvement program. So we have workshops interspersed with coaching activities, where we have our subject matter experts who will join with you to support you establish how you want to what problems you want to fix you've identified in your diabetic care services. So how you want to address those problems and what improvements you would like to make in relation to diabetic care. So you'll have on hand those subject matter experts to guide you through that process. But by the end of it, we'd like you to have an understanding of quality improvement and to have that application of quality improvement with regard to your services to people living with diabetes. So at this point, I'll just explain the objectives for this session, and then I'll stop and see if anyone has any questions. So we'll consider what matters and to whom and how we measure that. We'll then think through how we adopt that learning approach, so to quality improvement, and then we'll consider next steps. But before I move on, anyone got any questions about today or about the programme? So feel free to drop your comments in questions in chat, or alternatively unmute yourselves. And we'll take those questions. I know. I'll take silence as meaning we're okay to progress. Any point, if you've got any questions, post them in chat, please.
Let's do that.
Right. So the next thing, so a knowledge capture sheet. So the what, so what, now what. I circulated 10 minutes in advance of the session a knowledge capture sheet. Tamika, could you do me a favour, please? Could you please drop one in the message board so people can pick it up there as well. Now, the what, so what, now what framework as such allows you to capture your learnings from the session. So if you can't access the template, simple pen and paper will do. So the what is what did you learn, or what are the key issues and takeaways you'd like to take away from the session. The so what and the now what is a reflective activity. So that may or may not occur in session. It could happen out of session, but ideally before the coaching. So the so what is, well, what does this mean to me in my practice? So what does this mean to us from a practical point of view? What does it mean to our patients and the people we work with? And then the now what is, radio, now I've got this insight and understanding of what's important, who it's important to, and what it means to them. What actions are we actually going to take or could take to address those. So that's an opportunity for you to do the reflections. And those GPs who are online, there's a little template at the very end of that document that allows you to capture the hours you spend undertake doing that reflection, so that you could log that in terms of maybe reviewing performance. So because technically that's what you're thinking about. How do we perform? And Paresh, anything else to add to the knowledge capture or the link with CPD?
No, look, what I would say is this kind of reflective template's really simple. It actually comes from health. So it comes from a guy called Rolf, who was from a nursing background, and it's been really widely applied. So there's kind of an evidence base behind it. It's really simple, and so we just really encourage you to do it. It doesn't need to be too exhaustive, but it's just very simple. What did you hear? What did you learn? So what does this mean for me, my practice, the team I work in, and what are we going to do as a result? It's really as simple as that. Capturing it, if you're a GP, it's a really effective and easy way to get some of those CPD hours, particularly around those different categories as well. Because I think that's what some of the new CPD is really about, is the reflective element and the learning, and how you translate that learning into practice and meaningful outcomes for patients. So hopefully it will be a win-win if you do it. And like I say, it doesn't take much time.
Fabulous. Thank you. Radio then. So now I'm going to throw things over to you, to all of our participants. So we did ask if you could bring along a personal device to undertake a few short polls. So if you've got a handheld device in front of you, if you just sort of scan the QR code, alternatively, I will drop the link into chat for those of you who would want to access it on your browser. So this is a Menti poll. Once I've done this, I'll move across to the poll so we can see how many people are logged in and what the responses are. So everyone good with that? Yeah. So I'll just explain to Jane. So Jane's just joined us. So Jane, if you've got a handheld device available, can you please scan the QR code, or alternatively use the link provided in the chat function to access the poll. The code's there if you need it.
I just wait for you to do it.
So this is asking what motivates you to do what you do. We've got 4 people there, and we have how many people? We've got 25 people online. And for those people who are adding, you can add multiples. I'll just give you 2 more minutes.
And it doesn't allow you to put in multiple responses.
Oh, sorry. Sorry, I thought it did. If you've got any else to add, then just drop them in the chat and we'll do a synthesis of everything. I noticed a couple of people have dropped comments in the chat box. I think we've come to a natural conclusion there. So, Paresh, any observations, reflections, including the ones that are on the chat?
Yeah, let me just flick to the ones on the chat as well, and I'll open that. Look, I think it's fantastic to see the so many of those responses. I guess when we're thinking about this and we're really thinking about what we do, we really want to get to those intrinsic motivators, what really drives us, what gets us up in the morning. And in some ways, I think the responses we see here are not altogether surprising, because I think many of us who work in health because we do want to make a genuine difference. We do care. We want to help the patient. We want to help the families. We want to help the community. And so I think that comes through loud and clear through most of this comments. And then I think there's some specific comments there also, for example, around particular cohorts or particular groups of people. So I see closing the gap there as being First Nations people and trying to make a difference there. So yeah, I think great to see, very heartening to see, and I think very consistent with feedback we've had in other sessions and from other people. And I think it kind of reminds us of why we went into the work we went into. So great, thanks, Ange.
Thank you. So the next question we've posed for you. So again, this is via the poll. So recognizing the fact you can only do one post, so that's a learning for me, is what I want from you is an idea of those simple rules you would expect us to adhere to while we work with you across this program duration, but also those simple rules you would expect of others and expect of yourselves. So we'll be with you through to the end of June in this respect. So we'll be spending some time together. And what we were thinking is, if it would just be helpful if we could establish some ground rules. We'll take the feedback and the results, we'll synthesize them and share them with you. We always have fun in our sessions. I'm going to set a 2-minute timer. Just picking up on that first one. Right on then. Yeah. Reflections again, Paresh. If you've got more to add, feel free to add. They'll still come in while Paresh is talking. Reflections are no simple rules.
Thanks, Ange. Look, again, I think no major surprises. I think I love the stuff about having fun and learning. I think that's always great. I think there's some relational aspects around how we work together, around kindness, respect, etc., which is great. I love the one about no stupid questions. I think, and I'd really emphasize that one, because I think sometimes us as facilitators, when we're in this space quite a lot, we sometimes end up using jargon, which we don't necessarily mean to, but it sometimes just happens. So please pull us up on it and ask if we use jargon or we say something that doesn't make sense. There really are no stupid questions. Yeah, I guess one of the things I'd close, by saying is the most learning we get is by having conversations and dialogues, and the more meaningful those dialogues and conversations are, the more we learn and the more we get out of it and the more fun we have. And so it's great to see the sort of simple rules that have come up here, because I think they're all about those aspects that allow us to have those meaningful conversations and dialogues.
Fabulous. Thanks, Paresh. Radio then. So thanks for that feedback, because that establishes how we work moving forward. So the next activity, this is where you join in and you can participate. The next activity is thinking through what matters in diabetes care. And we posed these questions in advance of the workshop. So what matters to patients, families and carers? What matters to you and your practice team, so others as well? What matters to your practice as an entity or the service you provide? And what matters to other people within that care system? And then we'll come and consider, how do you know you're actually delivering it? So at this stage, this is where we get you to do some work and participate. This is a whiteboard. So I've just shared the link to the whiteboard, and I'll give you a demonstration before we break off into working groups. So what I need you to do is think through what matters to those key stakeholders. And then, right, wrong word. And once you've found your group, and we'll explain what your groups are, or explain who's facilitating your group. So we'll have 3 groups. It's just a matter of simply grabbing a post-it note, moving the post-it note to wherever you want it to be, and then typing in your post-it note, and you can size it. So it's as simple as that. So just pick one up, drag it and drop it, type and size. And what you can see is that it's color-coded. So it's color-coded, green for patients, families, carers, blue, yellow for your practice, purple for others. Now, for those of you who can't access the whiteboard, feel free to drop your comments in chat. So qualify who it's for, patient, you or the team, practice, someone else. And to make it, if I could kindly ask you to monitor the chat and drop it in one of the boards, that would be awesome.
No worries.
So Ali will allocate us to groups, but before we do that, have we got any questions from anyone who's online? We're all thumbs up. We all know what we're doing.
No.
Okay. So
It's action learning.
okay, I've allocated groups. Paresh, you're room 2, with Bernie, Ange and Katie, if you facilitate room 1, and Nat, we're in room 3. Okay,
Yes.
just bear with me. I'm going to now.
Sorry, bear with, just to let him know, we'll do that for 15 minutes.
15 minutes, okay, and I'll
Yeah.
bring you back in automatically. So
Yes,
that should
thank
be
you.
okay. Just give me a second.
Right, can I just check if we've got everyone back?
Yep.
Ideal. Right, we're going to take some feedback now from the groups. So I'm going to start with group 1, and when the others, so we'll just do this as sort of, we'll just give them through this 5 minutes. And if I could invite someone from each group to feedback on the themes as such that have emerged from your session. So we'll start with group 1. Can everyone see that whiteboard with the results from group 1? Let me take it down one. Yeah.
That's coming through, Ange. Thanks.
Right. Radio, group 1. Ready?
Yeah, so group 1, lots and lots of ideas and thoughts coming through in our group. For what matters to patients and family, there was a lot about feeling safe and not feeling judged about and the stigma associated with diabetes and being able to access care easily in terms of what matters to the patients. A lot of the themes about what matters to teams and practices was being able to deliver the care, having the right spaces for the care, but also how we evidence what we're doing. So what data we're collecting, how do we show the care we're delivering, and how do we know that it's working? And then some of the ideas that came through for what matters to others, which we hear a lot about, is keeping people out of hospital. The hospitals and the LHD would love that people are well enough that they don't need to go to hospital, that care is cost effective, and it, care in primary care is more cost effective than hospital-based care. So they were probably the main themes in our whiteboard, Ange, in group 1.
Fabulous. Anyone from group 1 want to add anything? All good? Hello, group 2. So group 2, do you mind adding or adapting as opposed to taking away from group 1?
Thanks, Ange. So we didn't actually in group 2 decide who was going to feed back. So would anyone like to jump in? Bernie, did you want to jump in, or do you want me to go? And you guys add. I'll take the silence as
You go. You go.
oh, okay. Please do feel free to jump in. Anyone from
Okay,
group
sure.
2. So look, I think we really focused on patients, families, and carers, and also started on team members before time got the better of us. I think the themes were very similar overall to what came from group 1. The issue around I think the thing that what's different that perhaps came out was this tension sometimes between what a patient may want and what a carer or family member may want, and that may sometimes be two different things. And the importance of services engaging with families and carers, because not all services engage with families and carers as well. So I think that was something I didn't hear from group one that was different. I think other things that we came up with in terms of what matters to patients, families and carers, different words, but a lot of it was very similar. Continuity was something that was emphasized, and affordability, I think something else. And the third thing I think is it's about that individualization. So understanding the patient's context. So what works in one area, in one place, may be very different to another area or another place, because the availability of services may be different, accessibility may be different, the community may be very different. And so I think that was something that came out as well. So maybe just emphasize that. Group two, anything I've missed there you want to add or emphasize? And then when it comes to team members, we didn't really get deep into that conversation, but it was really about making a difference and empowering people. So knowing you're making a difference and getting some verification and validation of that is really helpful. Maybe some of the ways you might get that is by the types of questions people ask you, as an example. And that's as far as we got before we were cyberspaced back into the main room.
Thank you. Thanks, Paresh. Anyone in group two want to do a shout out about anything else before we move on to group three? Any volunteers for feedback from group three? So this was facilitated by Nat and Ali.
Did you want to talk to Mika, or are you happy for me to do it?
You go now, Sally. It's all good.
Okay. So group three, just I guess a couple of things that may not have been mentioned was around the relationship you have with seeing a regular GP for ongoing care, access to medications in a timely manner, and seeing your GP in a timely manner. The second part, everyone being on the same page with patient care. Wendy had a few points around the whole team being involved, person-centered care and holistic approach. Just thinking, was there anything we said that hasn't been said? Just that third section there was around data, meaningful data, that type of thing, and then things that mattered to others, Department of Health and PHN, AHMRC, nachos, allied health, referral pathways, that type of thing. Did I miss anything? I was a bit late joining the group, but yeah, hope it's all there. Thank you. Thanks, Ange.
No. Oh, good. Paresh, reflections on all of that.
$10 Paresh, you're on mute.
Sorry. I was just saying, how amazing is 15 minutes with lots of intrinsically motivated people to get all of that wealth of thoughts around what matters so quickly. It kind of makes me think about why did we start with what matters? Unless we start with what matters and sort of think about how care should be provided to achieve those important things, then we often miss out. As we were doing that, certainly in the group I was in, and as you were feeding back, Ange, I guess one of the other thoughts going through my mind is like, am I surprised by any of this? I don't think so. I think we all would agree that those things are important. And then I was asking myself the question, and how often does this happen? And I won't answer that question, but we all know, I guess, from the experiences of care we provide, or even as consumers, for directly or family members of other people who might be consuming services, that sadly a lot of those things that matter aren't the reality for many. There's a lot of diversity there. And I guess that's why we're here, is to try and see what we can do from a quality improvement perspective to try and help meet that gap between what's desired, what's expected, what's reasonable, and what's realistic with the current state, and trying to fill that gap.
Thanks, Paresh. Now, the next activity is based on the previous one, and I'm really encouraged to see that in terms of feedback from a previous activity, people picked up on the fact that data is important, measuring what matters is important, having a suite of relevant indicators is important, not only for the individual patients, but also for you as practice teams, your general practice and others. So think about the PHN, think about the department, think about other key stakeholders. So measuring what matters is important. And when we come to quality improvement, we talk about data-driven improvement. And then we can measure, we can't work out and can't validate whether or not we've actually made any improvement in what we do for the care of the key people we provide services to. So in this regard, what Tamika and I are happy to do is just document in here what measures or what indicators you currently use or could use with regard to measuring what matters. So this one, we're going to take verbal feedback. So anyone want to shout out what measures or indicators you currently use?
Hey, Angeline, it's Sue.
Yeah.
What about patients coming back for their visits, like for their chronic disease clinics?
So that's the return of patients?
Yep.
Yeah. So
Sue,
number...
Yep.
I was just going to ask you, Sue, were you thinking there of specifically around care plan follow-ups, or were you thinking more general?
Yeah, patients coming in like for nurse-led chronic disease clinics or GP-led chronic disease clinics, patients that actually want to come back for their reviews.
Yeah, okay.
Anyone wants shout out?
Alex Coyle here. I mean, all the different clinical outcome measures, so, HbA1c, blood pressure, urine ACR, BMI, we know all the list, all of those things.
Yeah. Now, interestingly, in one of those feedbacks, there was a bundle of measures. And I think it may have been you, Alex, in group 1. So setting out the fact that it's not just one measure, your HbA1c, it's the your HbA1c. It's the whole bundle of measures that are important to the individual. Yeah, and the team. Yes. Any other measures?
Some of the patient reported measures or their experience measures. That is more of a qualitative, perhaps, than quantitative.
Any specific ones you're thinking about there, Donna?
I mean, we've often implement the PES, which is the patient enablement experience type surveys. So they're things around the satisfaction with the service. Did they feel valued? Was there, you know, their goals jointly sort of developed? Did they feel culturally safe? Those sort of things.
Okay. And can I just ask, like that example you gave, is that a general one, or is it condition specific? So is it diabetes specific?
No, it is more around a chronic disease.
Yeah.
And the other is about how do you, are you improving the understanding of the condition? Do they feeling confident to manage their condition, understanding medications, that sort of thing? So, but it's probably used a lot in the diabetes area. PESS.
I was going to say, you're going to have to help me out on that one. I'm not the clinician in the room. Any other diabetes specific experience measures?
Wendy's just got her hand up. Wendy, can you unmute?
I was thinking of mental health assessment tools. So there's some diabetes specific, but I can't quote you what they are at the moment. But
the diabetes distress scale is one, I think.
Yeah.
Yeah. Thank you for that. Anyone else use the diabetes distress scale? Any other measures?
Hospitalizations.
Yeah.
Oh, it's all gone to pot now. Yeah. And what do you measure for hospitalizations, Alex?
Oh, well, we don't specifically measure it, but I guess if a patient is hospitalised, diabetes is a complication or a cause of their hospitalisation, we certainly make note of it in their care plan and, you know, take more of an interest, I guess. That's an indicator more than a measure, maybe. I don't know.
Any others?
Being an allied health person, I would possibly say the engagement with allied health. I see a lot of EPC referrals come through as referrals. And, you know, if someone has IBS, they're very motivated to get to do something about it. But often if someone has diabetes, you know, there's probably about a 25% engagement rate with a dietitian. Because you can do something with medication, you don't really have to change your diet. So that's an interesting one that I often observe. Don't know whether that's right for other dietitians though.
Yeah.
I think the other one, looking at that annual cycles of care.
Yeah. Anything else you want to add? No. So if we go back to what matters to patients, what matters to you and the team, what matters to your practice or your service, what matters to others, does this give a fair reflection of that? I'm going to ask you to hang on to that thought as we move back to the presentation. Paresh.
And thanks, Ange. So this is really just a little video from a SharePoint site that we've created in the practice. I think I kind of started off to say I'm kind of particularly excited to be facilitating this because we're also doing work on diabetes as a practice and trying to improve that. And I guess one of the places where we've started is what matters to patients in terms of trying to capture that data. And the International Health Outcomes Collaboration, haven't got the acronym quite right, is ICHOM. They've done a sort of really engaging where they've involved consumers, patients, subject matter experts, specialists, GPs from multiple countries around the world, and looked at all that kind of data and to together come up with a wheel which kind of describes what matters to patients. And Ange, I'm just wondering whether it's worth flicking back to the whiteboard or the slides where we've got the wheel, where we can see the wheel.
The whiteboard?
I think you had it on the whiteboard, didn't you?
Yeah.
Yeah.
Indeed.
Yeah, so if we can maybe just zoom out a little bit, that's it. Zoom in a bit more. And so I think it's worth thinking about where we started the exercise around what matters to the different stakeholders, and then what do we measure, and then this is I guess what the evidence from around the kind of world through a co-design process has come to. And we'll just start maybe at 12 o'clock and work our way around clockwise. But we talked about patient-reported outcomes, and certainly the three things that came up there was psychological well-being, distress of the condition itself, and depression. And all three of those things can be measured. And you will have seen on the previous slide, Andrew showing in the SharePoint site we've created internally in the practice, we've actually created forms to capture all three of those as QR codes. So we're now beginning to really only as recent as last 3-4 months started to collect patient-reported outcomes around each one of those dimensions as a practice. Then if we sort of keep going round to this sort of 3 o'clock position, we've got acute events. So these are the complications as a result of diabetes that lead to an acute event being captured. So the question is, how are we capturing those and documenting those? So interesting, about the hospital admissions, and we'll come back to that maybe in a moment as well. And we've started now to code hospital admissions so every time we get a notification to say someone's been admitted to hospital, we put that as a code to say hospital admission, date of admission, and then in the free text, the reason for it. And then in our care plans, we've got a section in the care plans that document hospital admissions as well, but only for the last 12 months. So again, trying to just focus in on those acute events and when they're happening and how often they're happening. And then as we continue around to the 6 o'clock position, you've got those chronic complications. So micro and macrovascular complications, nervous system complications, and treatment complications. And then if we keep going round, we've got the what they call the vital status. So they're really talking about survival and mortality. We've now started to code cause of death in our clinical system. So when someone dies and we issue a certificate, we're coding that as to the primary cause of death. And then if we keep going around, we've got healthcare utilization and financial barriers to treatment. So again, we start to think about hospitalizations here, but it's also, I think, some of the other comments. So we had the comment around allied health utilization and how good are we at that, or how not. And that may be a reflection of just, availability of service, or it could be a reflection of, accessibility. So services could be available, but accessibility is hard, or affordability is hard. And so financial barriers to treatment kind of creeps in there. Now, as a practice, we're not really capturing that data at the moment, but it's something on the radar. And then we've got diabetes control. So, the HbA1c we were talking about earlier, and then we come back to the patient-reported outcomes. So I guess, what's the so what? We talked about the reflective model earlier. What have we talked about? We've talked about what matters to patients. We've talked about what measures we may be already using or could use. And we've talked about ICHOM. And so as a practice, when we kind of set out on this journey about 6 months ago to really focus on diabetes, we asked ourselves, so we did a similar sort of exercise, and we asked ourselves the question, so what? So what does that mean? And where we landed was, as a practice, what the so what and the now what for us was, well, if all these things matter, how do we start to think about measuring what matters? And we can't measure everything. Like, we've got to deal with the reality. So what can we measure? Where can we start? And what are the few things we can start to look at that we're not doing at the moment, that we can start to measure? And then how do we build on that? So if you like, that was the so what and the now what for us. And the SharePoint site Ange showed you, and you may want to just flick back to that again, Ange, was really a helicopter view of how, as a team in the practice, we were going to start to look at the care of diabetes. And so at the beginning, so at the top of the SharePoint site, so it's it kind of talks about the chronic care model. So that's a model we're using for all of our chronic care. And then when we think about diabetes specifically, we want to really think about knowing our patients, having that register of patients based on their clinical need, and knowing and measuring what matters to our patients. So that's what's the second bit of activity we did. And then the evidence and the bundle of care that's going to make a difference to deliver what matters, and then have reliable and robust processes and care pathways in place, so we know that care is happening in a reliable way, and then monitor that. So we're on the same journey, really, and that's kind of how we've approached it, sort of linking in what's important, what matters, what we can measure, into a bit of an internal framework.
Any reflections, anyone? Any comments, observations, questions for Paresh?
I think context is really important when we're thinking about this. The context in Canberra is very different to the context in Brewarrina, and we know that in Canberra there's a much more educated, more well-to-do population than in the rest of Australia. So I'm just wondering, what are the challenges you have in patient engagement there that are different to what we might find here, where we're dealing with, most of our practitioners will be dealing with amongst the most disadvantaged people in Australia?
Yeah, and I think, you know, that really good comment. Certainly, I think what came out in the second group we had, the breakout group in the group I was facilitating, was that the importance of that context. And so I think what one does in the area you're in is so dependent on that context and what's achievable. So in you know, by no means is anyone kind of suggesting here's a recipe and here's what you've got to do. It's really about looking at where are you, what's important, what's your population, what's the context, and then how can you deliver within that context what matters to people.
Great. Madam, I'm mindful of time. Are you okay if we push on, everyone? Yeah. This is a very little case study. So just to give you an illustration in terms of how you translate measuring what matters to individuals and people. So this is Auntie Irene. She's a Wiradjuri woman. She's 56, lives in Walgett. She's got a daughter and 2 granddaughters who she cares for, so they all live together. She works part-time at the local grocery store, and she's admitted to hospital with chest pain, diagnosed with type 2 diabetes. She's got a history of hypertension and depression, and she's actually instructed to go and see her doctor about HbA1c levels post-discharge. So this is what happens. Following a routine 715 health assessment, the Aboriginal health practitioner notes that Auntie Irene has got a HbA1c of 10.4 in hospital, but she hasn't attended a recent GP appointment for follow-up. She's had a routine foot check with podiatrist. The podiatrist knows she's got some reduced sensation and tingling at night. She subsequently had a medication review. Post-discharge, the pharmacist has picked up that Auntie Irene was discharged on metformin, but her medication history indicates she's not had her prescription filled regularly. Is this the typical scenario you were alluding to, Alex, when you raised the complexities of working rural and remote? Is this a fairly standard?
I think this story is familiar to many of us in the virtual room. Yes.
Yeah. Yeah. So what matters to Auntie Irene? So when Auntie Irene has engaged, she's explained that she's feeling worried about a hospital stay. She mentions her mum had had bad sugar and stopped her kidneys from working, and she died at Auntie Irene's age. So that picks up on the fact that the indicators relevant to Auntie Irene from a person-centered care approach is that psychological well-being. In addition to that, she's not only worried about herself and what's gone before, she's also worried about her family and who's going to look after them if anything bad happens to her. So she's worried about the cost of care. She hasn't been to have her eyes checked as yet. She hasn't been back to the clinic. There's an opportunity cost and a direct cost for Auntie Irene, recognising she was working part-time, and she's also looking after her granddaughters. Metformin, the reason she stopped taking it is because it made her feel sick. She couldn't afford to be any sicker and take time off work. She has had a visit by the pharmacist. But she's worried about Auntie Irene's sugar levels. And as I advised her that really she should be taking her tablets, or she might end up with those kidney problems. So if you go back to Auntie Irene's distress in terms of what happened to her mum, it's a real concern to her. But that picks up on the financial barriers to treatment. and also that diabetes distress, just living with diabetes. So this picks up on the fact that she gets that tingling sensation at night. So that's the treatment complications. And she can't sleep well as a result. So this is all impacting on anti-herein. But what we can see is from the conversations we have with patients, we can identify what's important from an outcome perspective to anti-herein. And when it comes to care planning, it's useful to then think how you reflect this in the care plan. If these are the most important things that are important to anti-herein, how are you going to deal with them in the care plan, shared care plan, and how are you going to measure the outcomes that are relevant to anti-herein? So that gives you a feel in terms of how measuring what matters can be applied at a person-centered care level for individuals. That's a very simple illustration. Any feedback on that as an illustration? Sound simple? Is it easy? No. So we've looked at and queried what matters. We've looked at what measures we could use to measure and report on what matters and to see whether or not the services we provide are having an impact on what matters to those key stakeholders. We need to adopt a learning system approach. So given the fact that this programme is about driving improvement, so we'll be working with you, as Paresh mentioned, to work out what you would like to address within your practice through the coaching sessions, working with you and adopting that CQI approach. So very quickly, I'm going to do another poll. And this one, so if you've still got it open on your phone, just do a refresh and it should take you to the next page. So this gives us a feel in terms of where you sit in terms of these three statements. I've dropped the link in the chat again, along with the code. I think we've come to a natural conclusion. Paresh, observations?
Yeah, thanks, Ange. I guess when I look at these charts, and one of the things I love about Mentimeter is it gives you the circles with the numbers in the middle, which is kind of your average or measure of central tendency. And we kind of see that with most of these questions, we're somewhere in the middle. What I think's really telling is the shadow behind, which kind of shows the distribution. So, you know, the first one around we measure what matters to our patients, very typical bell-shaped curve. But the second and third one I think are really interesting, and to an extent the fourth one as well, where we've got this, you know, really widespread across the group here around the use of data, having dedicated time to do improvement, and then tracking those changes as well to an extent. Quite a wide distribution. So that's really interesting. I think it tells us something about the diversity for a whole bunch of reasons within the group. I think it also tells us about the importance of coaching as well. So, one size fits all isn't an approach that we'd advocate, and isn't an approach that's going to work. I think there are some high-level concepts which will be similar across each and every one of us in terms of how we approach this. But in terms of implementing it and making the changes, it's going to be so context specific, as Alex, you called out very appropriately earlier. And so I think that's where the coaching really becomes important. Yeah, thanks, Ange.
Great segue. So, yes, this is a quality improvement framework that we'll be applying when we work with you in terms of the coaching sessions. So, Anini mentioned earlier that context is front and centre in all of this. So, what changes Paresh makes may not be relevant at all in your context. What changes you make may not be relevant at all in terms of how Paresh operates. So that's the primary focus. What's your operating environment? What are the key issues and challenges? What are the populations you serve in your communities? And then the next one is undertaking some diagnostics to work out where your problems and your opportunities for change are. Step 2 picks up on the model for improvement. So that's about planning and testing and using PDSAs to test whether or not your changes have led to an improvement before then you even think about implementing and embedding change. So when it comes to improvement, we'll sometimes come up with the ideas first without going through this framework as such, jump into solutions, and then think we can scale it without testing it. So this is why this process is important. And then when we think about how we've embedded that test and it's working effectively, then we think about how do we sustain and spread it. And as part of doing that, we think about how we involve patients, if we can, in that change activity. And how do we involve others, both internally and externally, if necessary? So thinking about the role of the PHN and practice development officers, how could you possibly engage them to support you? So, but in terms of driving improvement, this is very much about building a learning system. So I'm just going to, mindful of time, going to run through this very quickly. What we're looking to do when we're thinking about improvement is translating data to knowledge, then translating that knowledge into practice, doing things differently, and then collecting data from the activities we undertake, so practice to data, to then inform our knowledge. So we've got this virtuous learning circle going on. So the sorts of questions are: how well are we doing? Where are changes needed? What are the causes of these problems? What's your change hypothesis? So if we do this, we anticipate we'll achieve that. What changes will you make accordingly? And there'll be options there. And how do you measure what matters? What data will you collect? How do you monitor that change and report on that change? How do you review, reflect, gain insights on what you've done? And then how do you test whether or not you've made an improvement? Now, the likelihood is you'll be able to add a lot more questions to that learning process, and we'll come on to those in the coaching sessions. So that gives you a feel for the sorts of methods and processes will take you through. So, but good care is around adopting that population health approach, and to do that, the denominator is good quality data. And we recognise the variability in data quality within general practice, so we work with what we've got. And in terms of driving improvement, we think about how we can improve the quality. Now, Paresh is very keen on saying data cleansing is not an improvement activity in its own right. Data quality is the foundation of quality improvement and good quality care. So, but the purpose of data, Paresh, quickly, purpose of data.
Yeah, thanks, Ange. So it's really about telling a story. So what's the story that the data is telling us? And so really, in order to tell that story, we've got our data. We need to organize that data in some sort of structured way. Once we've kind of sorted it and organized that data, we want to present it in a way that helps us to understand what's going on, so we can tell that story. And I think most of the time when we're thinking about data, we're thinking about numbers. But actually, I think when we're talking about data, we're thinking numbers and stories, so quantitative and qualitative. So I think Auntie Irene's story is just as important as the percentage of people discharged from hospital. Like we need both to be able to tell the story, and so that's kind of the mindset we're going to adopt.
Yeah. Radio then, so questions, feel free to reply to my email, send me any questions or drop them in chat, and we'll pick them up in advance of the coaching session. So just to recap, this is what we've covered on today, what matters to diabetes patients, and we're moving into coaching round 1. So there's 2 opportunities on the 28th of Feb, lunchtime and evening, and I understand that Katie has collated your preferences and will be sending out, I think you'll get invites from Therese for those sessions.
Yep.
That's correct.
That will come to me.
Yeah, beautiful. So in terms of pre-work, so I'll be circulating this together with a copy of the slide decks. So we've just sent you, we'll send you a little worksheet. So we need to understand who your team is, your quality improvement team is, what your context is and what your operating environment is, what you measure and if you've got any results, what you don't measure but you'd like to measure, what are your key issues and challenges, what are your patients' issues and challenges, and what would you like to improve and how do you know that that's the area you should focus on. So in advance of that 28th of Feb, if you could just do that internally, and it doesn't need to be a thesis, just needs to be a few dot points. And this is your point of reference. And just to assure you, we're not asking you to share your data. All we're asking you to do is come along prepared for the coaching session. So for those of you who have eligible for CPD, in that worksheet and in your reflection sheet, we've put a little log so you can log reviewing performance, measuring outcomes, and Katie has confirmed that the program's accredited. So in terms of the educational sessions, so for those of you who participate, you will be able to get your educational hours.
Yeah, we'll upload those, Ange, for the GPs.
Yeah. So at this point, I'm going to say thank you and goodbye, and just point out if you've got any queries about anything to do with this program, please feel free to reach out to Therese, and she will hopefully resolve or come back to us and we'll be able to give you a response. So at this point, I would like to say thank you very much, everyone, for your participation, and look forward to seeing you on the 28th of February.
Thank you, everyone.
Thank you,
Bye.
Ange and Paresh. Thank you, everyone.
Thanks, everyone.